like to thank both the DNB board as well as the ABSI for this opportunity. Over the last session that we've had on breast cancer, you've heard numerous talks which talk about oncoplastic surgery, why we do what we do, and a lot about adjuvant therapy. But today, with the way things are moving, we're moving in breast cancer to biology-based therapy, and neoadjuvant therapy is coming to the forefront with that. So, what is our need for neoadjuvant therapy is the first part of the question that we'll address. Today, we use neoadjuvant therapy to downsize tumors, be it locally advanced tumors that we want to make amenable for surgery, or any tumor that we're allowing it to make it amenable for a BCS. It also today, with biological sensitivity, gives us in vivo information about the tumor sensitivity and what this tumor responds to, and allows us to prognosticate the tumor. So where do we stand today in terms of survival benefit related to neoadjuvant therapy? We're offering chemotherapy in the adjuvant. That is our standard of care. Suddenly we decide we want to downsize tumors, make them more amenable for breast conserving surgery. But does this addition of chemotherapy to the neoadjuvant setting improve survival? The first of the landmark studies was from the NACBP group, B18, where they added in the anthracyclines into the neoadjuvant therapy and evaluated whether it made any difference whether they were given adjuvant or neoadjuvant. We saw more pathological complete response, about obviously you're going to see it only in one arm, but we saw about a 13 to 14% PCR, which is what we know with only anthracycline-based therapy. In terms of survival, we saw no difference in survival. So it didn't matter whether you gave the chemotherapy adjuvant or neoadjuvant. We were making the tumors smaller, making them more amenable to breast conserving surgery, but we were doing nothing in terms of survival difference. I'd like you to remember that the NACBP B18 study, the tumor size, median tumor size at the start is approximately 3 centimeters, which means most of these patients were already amenable for breast conserving surgery. This is one of the biggest disparities between studies we see in the West and what our real world situation in India is, because of the difference in tumor size. As time went forth, we further increased the kind of chemotherapy that we give. So of the determinants of response to chemotherapy, one of the factors we know is amount of chemotherapy or type, cycles of chemotherapy and type of chemotherapy. So when taxanes were added into the armamentarium, when we looked at the study, which is NACBP B27, and we talked about whether adding the taxane into the neoadjuvant made any difference. Did it matter whether you sandwiched surgery between the two, or did the addition of taxanes improve the patient's outcome at all? This study also showed us a PCR rate increasing with increasing number of cycles and types of chemotherapy. So from that 13%, we went up to 26% PCR rate, but it still showed us no difference in survival. Now, the survival difference seen in this group was about 20% or so, was about 2% or so, but this study was powered or designed to detect a 20% difference, which is why it never reached statistical significance. You need a much larger study to prove this kind of question, and to do such a large study for such a small difference in or delta in survival would mean that the question may not be as relevant. We also looked at various studies which added targeted therapies. So there's the original NOAA study for trastuzumab, NeoAlto for trastuzumab and lapatinib, Neosphere for the addition of dual targeted with pertuzumab. All of these studies showed us increasing PCR. So you add in a targeted therapy to the standard chemotherapy. All of them do better in terms of PCR. That means none of them, unfortunately, have a survival benefit. So what we're seeing here is that you're increasing PCR, you're making it more amenable to surgery, but you're doing nothing for survival. So where does that make us stand today? Do we really need to offer neoadjuvant therapy to every patient, or are we happy to be able to operate the ones that are amenable for surgery? And what is our real role of neoadjuvant? So this is where response-based assessment and planning has come into the system. So when you have patients who are amenable to breast conserving surgery, if they are ERPR positive, you would be able to operate upfront. However, if they are triple negative or HER2 positive, then you need to look at the fact that if you gave them chemotherapy first, are we able to assess a certain change in the biology, response driven treatments after chemotherapy, which allow improvement in survival? So, the most common example cited is for triple negative tumors, be it the use of capecitabine in the adjuvant after neoadjuvant chemotherapy or the use of immunotherapy. The CREATEX trial was designed for all comers, ERPR positive, HER2 negative, or triple negative tumors. And we saw that after giving patients standard neoadjuvant chemotherapy, non-responders or patients who did not achieve PCR, when given capecitabine, had a 7% improvement in disease-free survival, which was as high as 13% for both DFS and 8% for OS in triple negatives. So this suddenly changed the way we're thinking about neoadjuvant chemotherapy. Now, neoadjuvant chemotherapy has helped you define whether a patient is going to prognosticate. I'm not going to say define. It's going to prognosticate your tumor. It tells you this patient's a responder versus not. We know in triple negatives and in HER2 positives, non-responders have worse biology and outcome. The minute you're a non-responder, this type of response-based assessment treatment allowed us to add in a drug into the adjuvant and improve their survival for that specific group. Today, we do not have a way of identifying which patient should get neoadjuvant or which should not. So for triple negatives and HER2 positives, we have moved towards giving more neoadjuvant therapy for all comers. The addition of immunotherapy with the keynote trials, the use of pembrolizumab in breast cancer in the neoadjuvant therapy, was also path-breaking in two ways. One, it showed us an almost 70% PAT-CR rate, and similar to the capecitabine group, it prognosticated triple negatives, and the non-responders definitely benefited with continuation of maintenance pembrolizumab rather than the placebo arm. Similarly, for HER2 positive, like with the triple negative, TDM1 in the adjuvant for non-responders showed a survival benefit. So if you have patients who have taken neoadjuvant chemotherapy with targeted therapy, they were randomized post-response for the non-responders to either TDM1 or continuation of trastuzumab, and we saw a reduction in risk for invasive cancers of as high as 50% in the TDM1 compared to the trastuzumab arm. This, I will say, needs to be taken with a little pinch of salt for both studies for the primary fact. One, cost needs to be included into the consideration. Prognosticating a tumor can create anxiety if you are unable to have your patient afford the drug that you're going to give them in the adjuvant setting. So you need to take this into the clinic very carefully. So where are we today in the clinic? If your patient is amenable to breast conserving surgery to start with, which is a T1 or T2 N0 patient, you have hormone positive disease, which you potentially would take up for upfront surgery. Why you take them for upfront, especially if they're node negative clinico-radiologically. Now with the new studies related to the use of CDK4/6 inhibitors for patients with more than 3 node positive, you're even moving down that pathway where you're adding in drugs if they come back node positive in clinico-radiological node negative cases. So for hormone receptor positive disease, you're more or less clear that you're going to offer upfront surgery wherever amenable to breast conserving surgery. However, for triple negative and HER2 positive, the NCCN guidelines has moved towards saying that even for T1 tumors, and I would say T1C tumors, you're going to potentially offer response-based assessment, which is give neoadjuvant chemotherapy observe response, and in the non-responders, based on prognostication, you would offer adjuvant therapy. Are we able to incorporate this into the clinic for all patients? So I'm going to tell you that there are multiple factors. This is what science tells us today. You need to look at cost effectiveness. You need to look at patient's ability to take the chemotherapy and her ECOG. Upfront surgery today is also a good standard of care for these patients, with numerous perioperative interventions that are available. The study from Tata Memorial Hospital on lignocaine showed us a difference in survival with a simple perioperative intervention of local anesthesia. And this was for all comers, irrespective of biology. So do we have a direct comparison between use of neoadjuvant versus surgery for the operable group? The answer, unfortunately, is today no. We are extrapolating based on other data, but we are looking to move this forward. And I know that Tata Memorial has started a study and is embarking on a study to answer exactly this question, and we should have results in a few years. So in early breast cancers, where does neoadjuvant therapy stand today? It prognosticates our tumors, gives us a certain amount of path response, allows us to offer a certain amount of downsizing for breast conserving surgery, which may not be relevant for patients that are already amenable for the same. There is still no survival benefit of the use of neoadjuvant. What it's done is it's prognosticated the tumor, and adding in the adjuvant has potentially changed the survival. Perioperative interventions also show a benefit of survival. So we need to now balance between offering our patients neoadjuvant based on histology versus perioperative interventions. And for T2 and above, I think most of us are now using neoadjuvant therapy, but for T1s, you need to balance it out with your patient's thoughts in mind. For any locally advanced tumors that are T3, T4, NEN, or any N2, N3 disease, our stand today would be to offer neoadjuvant therapy, downsize the tumor appropriately, and then offer surgery based on the clinical radiological response. So what is this surgery that we can offer? Does that mean that we are still where we were in the Halstedian era, where we looked at offering mastectomy to all patients, especially with advanced disease? Unfortunately, we are far from there. If your patient has operable breast cancer, but just not amenable to breast conserving surgery based on breast tumor ratio, based on both the NACBP B18 and 27, today we know we're achieving great PCR, or we're downsizing tumors with neoadjuvant therapy, and that is our way forward. All the data available is post-hoc analysis of these randomized trials. We're increasing the number of conservations with no difference in survival in early breast cancers. So what happens to all these larger tumors, more than 5 centimeters, or T4 disease? Can we offer breast conserving surgery and de-escalate surgery in them? So the two landmark studies were from MD Anderson and the Tata Memorial Hospital. Unfortunately, these are all prospective cohorts and not randomized data. The first one was from the MD Anderson group, 350 patients. I'd like to bring your attention to the fact that most of them are still stage 2. This is not what you see as locally advanced cancers with T3, T4 disease. This is slightly bigger disease, but not true BCs in the way that we see them. And what the MD Anderson group noted is that the risk of local recurrence post NACT BCT increased if originally they were N2, N3 disease, the pathological residual tumor was larger than 2 centimeters, there was multifocal pattern of residual disease, and there was presence of LVI. But based on this prospective cohort, they suggested that there was still a role for considering a BCT post NACT in even these locally advanced tumors. So the Tata Memorial Center looked at their prospective cohort, and in about 2006, they published this paper of 664 women who had undergone surgery post neoadjuvant therapy. 80% of these tumors included may have been T4, but only 28% of them were amenable for breast conserving surgery and underwent the same. What we saw was that at 30 months of follow-up, The relapse rate was fairly similar in both. The DFS was better in the BCT group, and so was the OS. Now, this sounds rather surprising. Why would breast conserving surgery do better than a mastectomy, especially when this is a group with large burden of disease? What you need to remember is this is not a randomized study. This is a prospective cohort. So patients that responded to chemotherapy were amenable for breast conserving surgery and then had the same. So biology is what dictated their outcome. Responders were better biology, did better. Non-responders with worse biology had mastectomies. So we were not able to show you a difference in terms of breast conserving surgery being better, but what we were able to say that it was not any worse than doing a mastectomy. There was then a meta-analysis of the 8 studies that were available in literature on this conversation, published in 2016. Again, all of these are prospective or retrospective cohorts, and most of them did not include T4 disease. But what they did tell us is that BCS was a safe option for a well-selected patient with locally advanced disease also, and that the local recurrence and DFS appeared to be the same. We've then moved one step further, where when you have response to neoadjuvant chemotherapy, clinically all the skin may look good, everything may have responded, but you get a lot of scattered multifocal response or you have extensive DCIS. Can you still continue to conserve these? And we've got a paper out of Tata Memorial which suggested you use flaps for reconstruction, large, wider excisions, and this is where oncoplasty came in a big way. So we're able to still continue to extrapolate from early breast cancer to locally advanced, and even in a post-NACT setting with a large residual multifocal response, one can consider oncoplasty in certain situations. So why is there still a debate if we've got a certain burden of evidence which tells us, yes, it's safe to have BCS post-NACT? The concern arises from the fact that we have long-term data which was evaluated in a meta-analysis. Now, this was published in 2018 and created quite an uproar when it came out. It was a meta-analysis of the studies that looked at patients that had undergone breast-conserving surgery post-NACT. They suggested that though there was no DFS-OS benefit, there was an increase in local recurrence with the use of BCT. Now, this was extremely alarming because most of us were using it in the clinic to offer NACT and downsized tumors and then offer BCS, and now be told that you would need to tell your patients there's a 5.5% increase in local recurrence. We know from the EBCTCG analysis that for every one local recurrence, there is an increased risk of death. So if you have a 5.5% increased local recurrence risk, you are potentially impacting her overall survival. So I would say, critiqued this paper, and where we noted were they had included 2 studies where surgery was completely omitted post-NACT. If you removed those 2 studies, then the local recurrence rate was not statistically significant anymore. And if you only evaluated those 2 studies, the local recurrence risk was as high as 13.3%. So factors that contributed to this increased local recurrence was not as simple as give NACT, do a BCT, you have increased recurrence. Part of it was omission of surgery, improper tumor localization, and a heterogeneous response that was not evaluated correctly. So mapping of disease today for any patient who's going to have NACT is essential. You need to mark the tumor. There are options available. The first being you place a core biopsy in the center or the summit of the tumor, but this is a fairly crude way. So the most robust way is to place a radio-opaque marker within the tumor at the time of either diagnosis or once the tumor starts responding, so by the second cycle. There are older studies that have used pre-treatment tattooing of the margins, but I think we have moved away from most of that with the available technology. Post-NACT mapping of disease, with the use of MRI is now coming in a big way. And if we are looking to do breast conserving surgery with complete safety, we need to offer all the technology our patient has. So what we see today is that you can have a single tumor which responds with a single focus. That's the most safe response. But when you look at the data from the MD Anderson paper, that's the first thing they told us. Risk of recurrence increased with this scattered multifocal response. Because unfortunately, if you don't map your disease correctly, you may excise inadequately and thereby increase the local recurrence. Large tumors responding with a single focus versus large tumors responding with multifocal disease need to be evaluated as separate entities. So where are we today on no surgery post NACT, the true de-escalation of surgery? So the EBCG analysis already showed us that the local recurrence rate in the older studies was as high as 13.3%. And this then was considered to be inadequately mapped disease, inadequately mapped PCR. Patients did not have appropriate use of technology to identify who had achieved PCR or not. So there are 5 studies that have embarked on exactly this question, looking at understanding, can you assess which patient has achieved PCR or not without operating? These studies were the Responder, NRG Oncology BR05, the post hoc, I'd say, I think it's a pooled analysis by Tassoulis and the MICRA trial. Of these, the NRG study has been published in Lancet last year. All these studies are using biopsies, which are stereotactic biopsies of the tumor bed, and assessing whether they are able to predict or identify, I think predict is the wrong word, so identify PATCR accurately. Some of the studies have added in the use of an MRI. Most studies are just mammograms with available vacuum-assisted biopsies. The false negative rate and sensitivity for all studies is fairly high. The only study which showed us some benefit was when they used more than 6 vacuum-assisted biopsies, where the residual tumor was less than 5%, less than 2 centimeters, and the FNR was able to drop to 5%. This effectively meant you're doing multiple bed biopsies in order to avoid a simple small lumpectomy, which may actually be simpler for a patient. So in today's era, when this review was published, we understood that we are unable to predict PCR because of the low sensitivity of the technology available. So omission of surgery still did not seem feasible. Then in 2022, the first of the studies was published officially in Lancet. I'd like to bring to your attention, even though they told us that it was potentially feasible to consider no surgery in a group that may achieve PATCR post NACT with accurate identification using MRI and VAB. What you need to remember about this study is it's 50 patients. Their tumor size at inclusion, which is the median tumor size of the patients who got NACT, is 2.2 centimeters. The final pathology or YPT size median is 0.909 centimeters or 9 mm. Only 17 patients had complete radiological response. The number of VAB specimens obtained, that means you've taken 15 biopsies for each patient, which effectively may amount to a lumpectomy. It's just that you're probably doing it with a smaller scar. I'm going to tell you that the follow-up for this burden of disease is very low. It's only 26 months, and I don't think we have the answers yet. Even though this was heralded as a landmark study, I think it has a lot of flaws in it. It's been critiqued severely by the peers, and we are today still awaiting more data. In today's era, we are not in a position to stop offering a lumpectomy because we cannot identify which bed has had PATCR versus not. So all of that is about the primary tumor. Where are we in terms of treating the axilla? So when you look at upfront surgery, we've gone from the era of complete axillary dissection to conservation even in the axilla. The first situation would be your patient has upfront N0 disease, is being operated for upfront surgery. So the role of sentinel node biopsy, which came from the NACT B32, is fairly robust. 5,611 women, a 9.8% FNR with 98% identification. Clean study told us that if you were to offer sentinel node biopsy using dual dye technique, you would be able to identify the sentinel node accurately and reduce the false negative rate and identification for your rest of the axilla. One of the concerns that it did address was that in 2.3% of these patients, the node that was the sentinel node was only palpable and did not pick up disease, any of the dyes. So this study changed the definition of what was sentinel node biopsy to not just what was picked up by the dyes, but also clinically suspicious and palpable disease. So today for sentinel node biopsy, you don't just identify the nodes that are stained by the dye, you also palpate the axilla and make sure that you pick up any large palpable nodes and send them as your sentinel node. The use of the various dyes started with blue dye, the technetium colloid, and now ICG. We've learned that the combination of two has helped identification rates. ICG now as a standalone dye also has acceptable identification rates. And if for some reason you are unable to identify the accurate sentinel node, do you need to now do an axillary clearance? Fortunately, we have data from the Tata Memorial Hospital, which was the low axillary sampling study. It allows you to do a low level one, which is based on certain landmarks below the intercostobrachial nerve, allowing you to continue to offer axillary conservation in situations where you are unable to identify a lymph node, as well as not having access to appropriate dyes. So when you look at a patient where upfront surgery, clinico-radiologically N0, axillary conservation should be the standard treatment that you offer your patients. But this has one flaw. If you do not have access to frozen section, then you have a 5% potential probability that you may want to go back in if these nodes come back positive. So that brings us to a study which talked about if your patients have 1 to 2 sentinel nodes positive, do you have to go back in and operate, or can you offer axillary radiotherapy? So this was the ACOSOG Z11 and the AMAROS trials. So the ACOSOG Z11, we compared to the Tata data and found that a lot of this in terms of just observation and using tangential beams to the axilla was not appropriate for the fact that the tumor burden in this real world population in our country is starkly different from that included in the trials, where the trial median tumor size is about 1.7, ours is about 3 centimeters. We have higher grade tumors, more LVI, more macrometastatic disease. So today, if you have a patient with micrometastatic disease, with truly early breast cancer of low grade, could you offer axillary conservation for a 1 to 2 sentinel node positive by using axillary radiotherapy? The answer is that as long as you offer some treatment to the axilla, I think that would be a safer bet than just clear observation as was offered in ACOSOG. So then we've talked about even these T1, T2s in triple negatives and HER2 potentially getting neoadjuvant chemotherapy for response assessment. So what happens to their axillas? So now just because we're offering chemotherapy, does that mean they have to have axillary clearance and all the morbidity that's associated with that? So how one explains why sentinel node needs to be rethought in post-chemo is when you inject dye in the tumor, it goes to the sentinel node. Post-chemotherapy, because of response in the lymphatics and desmoplasia, it may potentially go to, the dye may potentially go to a truly non-sentinel node, and it may not identify the axilla correctly. So, which is where we needed to move forward with numerous techniques and methodology in being able to identify where we stand today. So, if your patient is going to get neoadjuvant chemotherapy, if she's N0 to start with, then potentially you can conserve the axilla. So this was a meta-analysis as well as certain prospective cohorts. None of them were randomized data, which looked at N0 to start with. Your patients are getting neoadjuvant chemotherapy. Could you offer sentinel node biopsy? And I think the identification rates in the FNR have been acceptable, similar to that in the upfront setting. So for a CN0 patient, we're quite happy to offer that. But when should we do it? Prior to chemotherapy or after chemotherapy? And I think that debate has been going on for a while, but we've now reached a point where we are comfortable to offer to assess the lymph node prior to chemotherapy, do an ultrasound guided FNAC, prove that it is N0. Once you prove that it is N0 with ultrasound guided FNAC, if required, you are then able to offer sentinel node biopsy post chemotherapy because you know that the long-term outcome with this group is good. They're good tumor biology, and we're happy with that. Then we have a group which is going to be either N1 or N2 disease. For N1 disease, where will we, one group of patients will respond clinico-radiologically. That's the group that becomes N0 post-NACT. And then there's going to be a group that continues to stay node positive. Similarly, for the N2 disease. So there are 4 studies that looked at the role of sentinel node biopsy in patients who were node positive to start with and converted to node negative post NACT. The first of these studies was the Sentina trial. It had a detection rate of as high as 80%, which meant that we will be able to pick up these lymph nodes in 80% of the cases. None of these studies are randomized. These are all prospective cohorts, except for the Sentina, which was also not, I wouldn't say a randomized study, but a 4-arm study. What the Sentina did was you were either node negative to start with, then you had a sentinel node biopsy. If your sentinel node biopsy was negative, you continued and had no further treatment. You continued with your NACT and had a rebiopsy. If your node was positive, you took NACT and then had sentinel node biopsy. If you were node positive, you got NACT first. If you became N0, you had sentinel node biopsy. If you stayed node positive, you had ALND. So what we are discussing is arm C of Sentina. You were N1 to start with, got NACT, and then responded and became CN0, and then were offered sentinel node biopsy. Unfortunately, the false negative rate in this arm is as high as 14.2%. As we increase the number of lymph nodes that we identify, we were able to bring down the FNR, but only 34% of the patients had 3 sentinel nodes identified. The second of the studies was the ACOZOG Alliance trial, the Z71. Again, same question, high false negative rate in the CN1. The reduction in FNR only happened with the increasing use of more number of nodes identified. The SNFNAC had an FNR of 18.2 when 1 node was removed, and that dropped to 4.9 when 2 nodes were removed. But please understand, this is a fairly small study in comparison to the other 2. The GANIA-2 trial, which was one of the larger studies, 900 patients. Again, the FNR was still a little high and required us to add in more options to be able to reduce the false negative rate and offer our patients conservation post NACT. Again, there is a low axillary sampling alternative, even in the post NACT setting, where we are picking up more lymph nodes and where the flaw of LAS in the upfront setting was potentially picking up more number of lymph nodes. That has turned into a benefit in the post-NACT setting, where identifying more nodes has allowed us to reduce the FNR of 9.9%. Now, the point I would make here is that the morbidity is being the reason that we offer our patients axillary conservation, requires us to prove in low axillary sampling that the morbidity continues to be low. And that study is ongoing and should be available, I think, in another year or so, where we would compare between low axillary sampling and sentinel node biopsy in terms of morbidity. So today, for a patient with node positive disease who becomes N0 after FNAC, you will realize that all the 4 studies have an FNR which is higher than 10%, which isn't really acceptable. LAS is among the first few procedures which showed us a reduction in FNR post NACT. So how can we reduce this false negative rate? The first was the use of dual dyes and dual tracers. Identification rates improved, and of course, picking up more nodes. The minimum standard today is to identify at least 3 nodes, especially in the post-NACT setting. And if you go back to the NACBP B32, the original trial on sentinel node biopsy, even there, the FNR for just one node was much higher, and it was almost about 17% compared to the FNR when you added in the 2 and the 3 nodes. So 3 sentinel nodes is what we accept as a standard in terms of best FNR that would be acceptable for us. Unfortunately, post NACT, identification of 3 nodes has not been in a large proportion of the patients in these studies. So what else are we able to do? So this is what targeted axillary dissection is. Targeted axillary dissection means that you have clipped or targeted the lymph node prior to NACT. So you can either place a mag seed in it, which is unfortunately not available in India, or you place a clip in it. The flaw with the clip is, or with any of these identification markers, is that if you have complete response, which we saw with increasing number of chemotherapy cycles, smaller tumors, increasing types of chemotherapy, targets that we are adding, our PCR rates are going up, which include the axilla. So you are then going to have lower burden of disease, often have complete response in the axilla, and you will have this clip floating freely in the axilla and not be able to identify it. And lack of identification is one of the bigger concerns rather than just being able to offer SNB or not. But for the patients that do continue to have disease, the clipped node was not the sentinel node in 30%. And I'm going to take you back to that first cartoon when we started post NACT, is because the dye may go to another lymph node because the pathway is now obstructed by desmoplasia. So to be able to truly reduce the FNR to as low as 1.4%, the clipped node also needs to be identified in addition to identifying 3 lymph nodes for sentinel node biopsy post NACT and being able to do targeted axillary dissection. Are we where we discussed, if you have node positive disease or you were CN plus to start with, could you now offer your patients NACT RT post sentinel node biopsy? So there are studies similar to what was the Amaros trial in the upfront setting that are ongoing for the post-chemo, and we still await the results to be able to offer them. So where do we stand for the patients today who are having NACT? If they were N0 to start with, we can continue to offer them SLNB post-NACT. That's the safest group in which SNB can be offered. But albeit you have assessed this N0 accurately using ultrasound with good technology and done an FNAC wherever suspicious. The other scenarios, or if you have N1 disease and your patient became N0, I'm going to say still needs to be under controlled settings because you need to identify at least 3 nodes, try and offer targeted axillary dissection wherever possible, and it needs to be done very carefully in carefully selected patients. For all other groups, be it N1 who continue to stay N1 or any N2 at the outset, we would today still offer our patients axillary dissection because none of the data available today allows us to conserve axilla in these 2 situations. So in conclusion, De-escalation of surgery is possible only because of the use of neoadjuvant chemotherapy. For the primary, if you have an operable tumor to start with, de-escalating to breast-conserving surgery comes from the post-hoc analysis of B17 and 27, 18 and 27. If you were locally advanced, there is prospective data, but primarily for T3 disease. For T4, I think we still need to be careful. For node positive disease, we have moved towards more sentinel node biopsies with neoadjuvant therapy. And the biggest change today for us is using biology to dictate our outcomes and our adjuvant therapies. So offering response-based evaluation for T1C and above seems to be the way forward, but we need to be careful in understanding if you cannot map your disease accurately, at least offer your patient good surgery at the outset. Thank you very much, and I'm open to take any questions that we have.
Yeah, thank you very much, Dr. Neeta. Trainees, you may type your questions, comments in the chat box.
So the most feasible way for TAD, unfortunately, is not available in the country. It would be a mag seed, which means placing a magnetic seed into the axilla prior to chemotherapy and then identifying that. That's what's currently done in the West. Um, for us, it is placing a clip and then trying to identify the clip post NACT. Sometimes one requires to place a wire in the axilla prior to surgery to identify the clip. It's quite cumbersome for patients, and it isn't where it's not the easiest technique to do, and it is definitely not the most comfortable for patients. So, which is why we're still struggling with that. So the sound study currently with the use of ultrasound to avoid surgery, I think if you go back and you see the data, it's very clear on the fact that most of their patients were node negative to start with. It's very early disease. Um, I don't think the follow-up is long enough to be able to answer the question that it's looking at. So I think that today evaluating the axilla with just ultrasound rather than the use of sentinel node biopsy, I don't think we're there yet. And I think that the sound trial is getting critiqued quite a bit in peer. Sorry, I feel like I missed a question somewhere. Very okay. Survival benefit for BCS over mastectomy. So in the upfront setting, there is a cohort data which was published from the Netherlands. This data suggested that in T1N0 patients, there was actually a survival benefit in the BCT group. Again, please understand, prospective cohorts are not the most robust data. What they also do is that they will, there's a lot of bias when you're looking at that. And a T1N0 group, getting upfront surgery, is BCT really better? Very difficult to answer that question, but what it did suggest is that you're adding radiotherapy to that group. So potentially that's where a certain amount of the survival benefit is coming. But definitely, that in the upfront setting, there's no question on the safety of BCT as long as your margins are negative. So well mapped, well identified disease. In the post-chemo setting, today, none of the data tells us about survival between BCS and mastectomy, because like I showed you with the Tata Hospital study, most of the difference in survival is because of biology, not because of the type of surgery. Small primary with N2 disease, can we offer BCS and ALND? I'm going to tell you that if your patient has N2 disease, you may be better off offering NACT. Mark your tumor appropriately, because if you leave back disease in the apex, you will struggle with a risk of recurrence and you're not benefiting your patients. Is carbon or clipping better for having better FNR? Clipping is better. So, but it's not as easy to do. Initial slides. I don't know how to show these slides again. Can we offer level 1, 2 dissection and CN0 of YPT post NACT? So the concern here is that when you look at offering only level 1 and 2 dissection rather than going to level 3, the concern that arises is, where was your node to start with? Were you able to identify whether this was just a single node in the axilla? Was this N2 disease with multiple matted nodes? Because if it was N2 disease with multiple matted nodes, you'd want to go one level higher. And for N2 disease, you do need to be more careful. You're never going to offer axillary conservation. If it was a single node, which was low level 1, responded to chemotherapy, you were able to tag that also, then you may potentially even offer sentinel node biopsy to someone who's responded. Pre-NACT N2, no reason for not doing SLNB is because in the studies that we quoted, which were the 4 studies on SLNB, N2 disease is less than 5% of the patients included in the study. So today you have zero evidence to be able to do an SNB in patients who were N2 to start with. Can we have the slides? I think that you'll have to ask the DNB organizers, my dear. Axillary RT only if there are micromets. So when you look at the Amaros trial, it was 1.4 centimeter median tumor size. 44% of the patients had micrometastatic disease. They are mostly low grade or T2 disease, grade 2 disease. They are 70% ERPR positive disease. The point is, if you have low burden, low risk disease, and then you get 1 to 2 nodes, sentinel nodes positive, you could consider axillary RT over ALND, because the concern is related to lymphedema. But within the Amaros trial, the lymphedema rates quoted for surgery itself were much higher than what we see in real world data. So what you actually need to then look at is that what is the difference between going back in versus increasing morbidity of axillary RT. It also depends on the type of axillary RT that you're offering, the type of technology that your radiation oncologist is using. Please understand, extrapolating data from the West to our real world situations is very different, because our burden of disease is different. The technology available in our country is not uniform across the board. So the options being offered sometimes need to take into account what is the simpler procedure to do for a patient. Initially, T3, T4, N1 post NACT, good response. Again, axillary management. Today, I'm going to be honest, for T3, T4, for T4 disease, I am not really comfortable conserving the axilla. I would at least do a low axillary sampling, if not complete level 1. For a T3 disease, I think a lot of the conversation is moving towards being able to offer sentinel node biopsy. We await more robust data to actually be able to do that across the board. How sensitive is PCR as a surrogate for OS? So there is no surrogate for OS. PCR is a surrogate for disease-free survival only for triple negative patients. It's actually a very bad endpoint to use for FDA approval of various drugs, but it has become that because it's easier trial endpoints. Only in triple negative, because you're not offering anything after that, does it correspond with DFS. Other than that, it really does not correspond. In any of the other subtypes, it does not particularly correspond to survival. How to approach initial LABC with post-op YPCR? Do we treat the response or continue adjuvant as per the initial stage? You always treat as per the initial stage. Your plan gets decided at the outset. The YPT that you get, or the PCR that you get after neoadjuvant, is only dictating biology. The only place that you would change adjuvant is where, like I told you, with response-based assessment, that if your patient has received, is triple negative or HER2 positive and has received all chemotherapy upfront, still not achieved PCR, You may want to add in, not remove. You may want to add in more drugs into the adjuvant so as to be able to treat whatever was potentially residual micrometastatic resistant disease in their body and improve their outcome. What is the data on axillary recurrence after SNB? So when you look at the studies related to upfront, that is upfront SNB from the B32, the axillary recurrence rate, correct me if I'm wrong, is 0.01% and 0.03% between SNB and ALND. Absolutely no difference, both in axillary recurrence, DFS or OS. The same thing when we bring to the post-NACT setting, there is some follow-up data from the MD Anderson and the GANIA-1 trial on N0 being offered SNB post-NACT, and that follow-up data also seems to suggest it's safe. The follow-up data, excuse me, the follow-up data for the post-NACT SNB in patients who were CN1 to start with, very small data available from the GANIA group, but I'm going to tell you that that answer is not very clear, which is why most of us are still very, very cautious in offering SNB in the burden of disease that we see in our patients today post-NACT. Upfront, no question on N0. N0 patients upfront or post NACT, I'm going to tell you that the safety seems to be fairly robust. One is an absolutely perfectly well done randomized study. In the NACT setting, N0, the disease burden, the disease biology is suggesting that it is different. Patients with node positive disease, axillary recurrences, one that you see, you will not forget for your patient. That kind of pain is extreme for our patients. Every patient that you're offering de-escalating surgery needs to understand that there is more stringent follow-up that one continues to do. Can you suggest potential future topics in CA breast? A lot of it is going to move towards biology and translational medicine. The first of which, is something I've been pushing a lot of people to do, is try and identify which tumors will potentially be responders versus not. I had done one when I was with Tata where we looked at triple negative tumors who had responded versus not out of our randomized trial. And we were trying to find a signature. We're still working on that. We're trying to find a signature which tells you which patients will achieve PCR or not. And if we are able to then decide which group should get NACT or not, just for response-based assessments. Other potential research topics, I'm telling you, would be one of which I think Dr. Joshi in Tata has embarked on, is a randomized study on axillary conservation post-NACT, and lot more translational work. There's immense work going on in the perioperative setting, which is using drugs while offering surgery to your patients and being able to change outcomes based on that. We need to move away from pharma, need to move towards more local concepts, more low-cost interventions so that they're available for the country to use at large. Role of axillary RT post-NACT, like I told you in my second last slide, those studies are still awaited. They're ongoing. I think we'll only know when they come out. One of them should be presented this year. Trials to refer to. There are a lot of trials, unfortunately, in breast. What I will tell you is know at least the landmark studies. So when you look at why we offer breast conserving surgery, that's NACBP B0406. There were 6 studies which looked at BCS in the upfront setting. Those 6 studies you should know. They're available in all the meta-analysis. Know all the EBCTG studies. They're very well done meta-analysis that tell us all our current evidence for treatment of breast cancer. When you want to do axillary conservation, NACBP B32 is the landmark study on sentinel node biopsy. You then need to know ACOZOG and AMROS for 1 to 2 lymph nodes. You also need to understand what the limitations of each of these studies for acceptability in our country is, not just accept what the West is and extrapolate it to us. You also need to know the LAS studies from Tata Memorial Hospital, both in the upfront and post-NACT setting, all the NACT trials that I told you in SNB, the meta-analysis, the MD Anderson and Tata Hospital study on BCS post-NACT. There's also one from TMC Calcutta that's been published recently. In addition to that, you need to know Createx, you need to know Catherine, and you need to know the keynote trials, because that's why you're offering more response-based treatments, even for early breast cancers today. Unfortunately, there isn't a I don't know what the right word is, but we used to call the quick guide to breast cancer. Breast cancer is changing every couple of hours because there's so much research going on. We have today been able to offer our patients outcomes that are as high as 93% for early breast cancers. And we are still striving to improve that. The bigger concern in our country is pushing women to come in early, diagnosing early, because that difference in survival also comes from delayed outcome and delayed stage. Status of TDM1 in our country in HER2 positives. So fortunately, there is one drug available, which is an Indian generic now, and it's improving the accessibility to TDM1. An example I can give you is when trastuzumab came out, and that was 2006, 7, I think. And we looked at patients who were getting trastuzumab in Tata Memorial Hospital. We found that in 2008, only 8% of the patients eligible to receive trastuzumab were getting it because of cost. Of those, 4% got it out of the various trials that they were participating in, and only 4% were able to afford it. We moved to 2016, where we reevaluated our numbers, and we found that now, since the patent had moved, there were multiple generics available. We were offering numerous short course regimens, and we had a lot of philanthropy come in for 1 year to short course therapies. Suddenly, we had over 70% of our patients getting trastuzumab and having access to it. This big jump primarily came from change in cost. So I think similarly with TDM1, what started out as much more expensive, that first generic is changing the way we are accessing her TDM1 in our population. Still not very cheap. I think it costs 66,000 rupees per cycle in the adjuvant, but it's definitely better than where we were. And I think it's only going to keep getting better from there as new generics come up. Is dual dye compulsory for sentinel node biopsy? So if you're using a dye that has a better identification rate as a single dye, you don't need to use dual dye. So identification rates with ICG are fairly high. I think it's about 98 to 99%. So that's been used. But I find when I use ICG, I'm picking up much more nodes. I struggle more with that. When you use only methylene blue, your identification rates can be as low as 83%. And that's a bigger concern because then you're doing more wider dissections trying to find the nodes. So which is why dual dye is not compulsory. But I would say if you're using a single dye, then do single dye based low axillary sampling. Low axillary sampling is advocated for our country, and it's primarily because it's a low resource setting. We've at no point of time has the Tata Memorial Hospital said that it needs to be the treatment of choice. It's one of the options we can offer our patients. We look at doing methylene blue guided low axillary sampling. That's what the standard needs to be if you don't have access to the other dyes. You cannot use just one or the other. It always requires you to palpate the rest of the axilla. And what's the benefit or the beauty of doing methylene blue guided sentinel node alone versus doing it as methylene blue guided LAS is if you were to do just methylene blue guided sentinel node biopsy, your experience and expertise in palpating the rest of the axilla is what's going to define that patient's risk of recurrence or inability to identify the correct node. And I don't think that's fair to that patient. You need uniformity and reproducibility of a procedure, which then comes from a low axillary sampling, which is defined by anatomical landmarks. So that's what's going to allow you to get correct FNR for your patients. So I think all questions are answered, sir.
Dr. Neeta, I hope you have seen the chat Q&A as well,
Yes,
right?
well done.
Excellent, ma'am. Excellent. So thank you very much, Dr. Neeta, for the presentation, and thank you very much, trainees, for joining us.